sirs, madams, my seniors, colleagues, and friends. So, as you all know, the topic of today's discussion is chest imaging. In COVID-19 with emphasis on standardized reporting format. So as Suresh sir already told, in this COVID era, this topic is very important because as we all know, all the COVID cases are skyrocketing, and almost nowadays we tend to see more COVID cases. Previously, only the government hospitals used to take COVID cases, and now from the last week onwards, all private hospitals have started taking up COVID cases. So as radiologists, we should know the imaging findings, as well as we should all report in a standardized way so that there will be no confusion on our communication of the findings to the clinicians. So the main aim is that I'll be stressing more on the standardized reporting format and also on the scoring of each the imaging findings. So this is the overview. I'll be dealing with the indications, the imaging modalities, that is chest X-ray, CT, and lung ultrasound. I'll be stressing on the standardized reporting format and the scoring. So I'll be going with the WHO recommendations of chest imaging. They have actually come up with a rapid advice guide, which is published on 11th June 2020. So according to the recommendations by WHO, for asymptomatic patients, for asymptomatic contacts of patients with COVID-19 and for symptomatic patients with suspected COVID-19, when RT-PCR testing is available, there is no indication for chest imaging. So that is the main thing. So previously we used to diagnose COVID-19 pneumonia by chest imaging, mainly CT, but now there is no role for that. So we are not taking the chest imaging for patients we are suspecting. So diagnosis is only by RT-PCR now. I think there's some problem with my slideshow. One second, let me check. When I clicking the next button, it's actually skipping to more slides. So does anybody know how to solve it?
It is more likely a key problem with your computer. Instead of right arrow, you select down arrow or up arrow.
No, I'm using the down arrow and up arrow.
There is a right arrow and left arrow. You just advancing, you use right arrow.
Okay, let me see. Because when I'm not using the slideshow, it is going like this. But only in the slideshow, when
maybe it is automatically set. Show is set with an interval.
Okay.
That has to be cancelled. Put it as manually. Yeah.
Okay.
Right.
Yeah, now it is okay. So sorry for the disturbance in between. So one second. Hari. Sorry again. So we are dealing with the indications. So we said that for diagnosis right now we are not at all using chest imaging. So what is the main indication now? That is, if the RT-PCR testing is not available, or if the RT-PCR testing is available but results are delayed, these 2 points actually it is not very important now, because we know that everywhere now the RT-PCR testing and the rapid antigen testing is available. So right now the indication is that when the initial RT-PCR testing is negative but with high clinical suspicion of COVID-19, so only in those cases we actually now use the chest imaging for diagnosis. Otherwise, for diagnosis we actually don't use chest imaging. And the WHO has also given the following recommendations, that is, in patients with suspected or confirmed COVID-19 not currently hospitalized, that is, for patients who are not currently hospitalized, the patients with mild symptoms, usually we don't take chest imaging. And with patients with moderate to severe symptoms, that is the main indication, is that is all COVID positive patients with moderate to severe symptoms, the indication is to take a baseline chest x-ray, and then if needed CT or ultrasound, and to decide on the regular ward admission versus the intensive care unit admission. And for hospitalized patients, we take chest imaging for all patients, that is with moderate to severe symptoms, to decide on therapeutic management, and also for patients who present with complications of COVID-19. And in patients whose symptoms are resolved, to inform the decision regarding the discharge. So the take-home point is that we are right now doing, or imaging is indicated only for COVID-19 positive patients with moderate to severe symptoms, to decide on the management and to know the complications of COVID-19. And if the RT-PCR is negative, we are strongly suspecting COVID-19 also. That is the only condition where we are using it for diagnosis. Otherwise, it's mainly for the management for patients with moderate to severe symptoms. So this is in a nutshell. This COVID screening, chest imaging has no role. COVID suspect, there is no role except if we are strongly suspecting the RT-PCR is negative. We know that false negative rates are very common in RT-PCR. So in those patients, we can take chest imaging. And there is something called COVID incidental. COVID incidental means if a patient comes for CT abdomen, because the patient has other clinical picture like acute intestinal obstruction or acute abdomen, we are taking a CCT. So it is always better to take a CT thorax along with the CCT abdomen, so that we can actually diagnose any incidental COVID. So that is actually helpful for the clinician or the surgeon, because we are taking the patient directly to the theater. So before waiting for the RT-PCR, we can just screen the chest if the patient has an incidental COVID. That is the only indication where we diagnose an incidental COVID pneumonia if we are taking a CCT abdomen for acute abdomen. And this is the COVID confirmed cases, mild case, no role. If the patient is high risk, that is, if the patient has a chance of progression of the disease, that is patients with comorbidities like morbid obesity, diabetes, hypertension, immunocompromised, or a chronic liver or kidney disease, we can take a chest imaging. At least we can take a baseline x-ray. So if the patient is high risk, even with mild case, we can take a baseline chest x-ray. Otherwise, no. And this is the real indication, that is COVID confirmed with moderate or severe case, we should take a baseline chest x-ray. That is the mainstay of imaging. And then we can then decide upon the CT or the POCUS. So coming to the chest x-ray, that is the mainstay imaging tool to diagnose COVID-19 pneumonia and aid in decision pathways and management. The advantage of chest x-ray is that we all know, because we are using a portable x-ray unit, we can actually keep a dedicated portable x-ray unit for the COVID ward or the COVID ICU, so that there is very less chance of contamination, and where there is less chance of spread of infection. So we can actually keep a plastic cover over it, and it's very easy to disinfect it also. And we don't use that portable x-ray units for other patients. That is the main advantage. And the disadvantage is that you all know it is insensitive early in the disease, because if you take chest x-ray in the first 3 days, most of the cases it will be negative, the lungs will be clear, but definitely sensitivity increases as disease progresses. So chest x-ray is the main use is that it is a useful diagnostic tool for monitoring day after day the rapid progression of lung abnormalities in COVID-19. So this is actually what I have told, that this is taken the second day, the chest x-ray for COVID positive patient. It is clear we are not seeing any lung abnormalities, but uh, the corresponding CT showing some ground glassing in the right lower lobe, which is usually the early finding in COVID-19, which is missed in chest X-ray. But that is not a problem. We can actually take a serial X-rays for looking the worsening of the condition. So this is actually the main role, that is by the regular monitoring. So this is a chest X-ray of a COVID positive patient, and this is taken as 4 hours, 24 hours, 48 hours, 72 hours, and definitely we are seeing that progression. We are seeing here multifocal pneumonia, and you're seeing more alveolar opacities here. And here, actually, it's almost going into ARDS or the whiteout lung. So this is actually the main role of chest X-ray in COVID-19 imaging. So now coming the importance of a standardized language. So previously we used to report, I don't know like how many hospitals radiologists are reporting X-rays. Most of the hospitals, the clinicians itself are interpreting the chest X-rays, and radiologists or the clinicians used to write a vague language, that is patchy opacities here, heterogeneous density, pneumonic patch, consolidation, like that. So now lies the importance of a standardized language which establishes uniform reporting regarding the presence of pneumonia and its extent. And it reduces reporting variability, and it provides clear communication for clinical decision making. So this is actually proposed by the RSNA, that is the Radiological Society of North America, and the American College of Radiology. So they have actually come up with 4 terminologies that we should use for reporting a COVID-19 chest X-ray. So we should either report it as negative, indeterminate for pneumonia, focal pneumonia, or multifocal pneumonia. So you should actually only use these 3 terminologies. So I'll come to it one by one. So this is a 54-year-old male with a lot of comorbidities coming with low-grade fever. So here you can see the patient has cardiomegaly and he has a pacemaker, but the lungs is clear. So for this case, we can give it as lungs clear, cardiomegaly is there, chest X-ray, no pneumonia. So if the lungs are clear, we can give the report as chest X-ray. So that's the short form, CXNP. So that is how we report in a normal lungs. Another case, it's a 59-year-old coming with cough and shortness of breath. There is some increased markings in the right lower zone, but luckily this patient had a previous X-ray which again showed the same findings. So here the teaching point is that if the patient has a previous X-ray, should always compare with a previous X-ray. And if the findings are same, then also we should give it as chest X-ray, no pneumonia. So if either the lungs are clear, or if the patient has some findings which is seen in the previous X-ray, we should report it as no pneumonia, because the patient has no new findings. Now coming to the next case, this is a 33-year-old male coming. He is a known case of dermatomyositis and interstitial lung disease coming with new onset dyspnea. So here we can see some linear opacities here. It is not frank pneumonia. We can't call it as pneumonia or a consolidation. Some linear opacities here, and we compared with the previous. It showed, and there is a suspicion of a new finding. So in this case, we can give it as linear basilar opacities bilaterally, chest X-ray indeterminate for pneumonia. That is CXIP. So we give indeterminate for pneumonia when there is linear opacities which is not consistent with consolidation or pneumonia. So in this case, actually we can take a CT. That is the only condition where a CT is indicated. And if the RT-PCR is positive, we can actually just follow it up the patient. But in this case, RT-PCR was negative. So the CT was taken, and because the patient was a known case of ILD, the patient had a previous CT, so the findings were almost same. So this patient actually had a flare up of her ILD, not COVID-19 pneumonia. So this indeterminate of pneumonia can be an early COVID-19 pneumonia, or it can be something else. So if the RT-PCR is negative, a CT chest is indicated for further confirmation. Otherwise, there is no need for a CT chest. We can just follow it up the patient if the RT-PCR is positive. The next case, it's an 80-year-old female. She has a strong exposure and now presenting with cough and dyspnea. So here in this chest X-ray, we are seeing bibasilar interstitial opacities, linear opacities. Again, it's not consolidation, some linear opacities. And here also we can give it as chest X-ray indeterminate for pneumonia, that is CXIP. and a CT chest was taken, which actually showed the typical findings in COVID-19, that's the peripheral ground glassing. So this is typical COVID pneumonia in CT chest. The RT-PCR also came as positive. Because we are not seeing a frank pneumonia, in chest X-ray we can give it as indeterminate for pneumonia. Ideally, we can actually just follow up the patient. No need for CT chest because the patient has a RT-PCR positive result. Next case, it's a 80-year-old male with so many comorbidities coming with fever and shortness of breath. Here also we are seeing so many interstitial opacities there in all the three lung zones. Again, no pneumonia. We can give it as chest X-ray indeterminate for pneumonia. And see, the corresponding CT chest showed peripheral bilateral consolidations more in left side. Again, typical COVID pneumonia, RT-PCR also came as positive. In this case also, actually, there is no indication for a CT chest. We can just need a serial follow-up chest X-rays.
Mm-hmm.
Now, coming to the fourth terminology that we have to use, that is a 43-year-old male coming with dyspnea. And here you can see a right lower lobe opacity here. So right lower lobe opacity, we are seeing a patchy consolidation, but rest of the lungs are clear. So in this case, if you are seeing a focal consolidative patch, we should give the report as chest X-ray focal pneumonia. So it can be an early COVID pneumonia or it can be a bacterial pneumonia. So that we can decide according to the RT-PCR result and other clinical findings. So in this patient, the RT-PCR is positive. So this is an early COVID pneumonia, but because we are not seeing bilateral, we should give the report as focal pneumonia, needs serial X-rays, not CT chest. So another case, a 55-year-old male coming with cough and fever. You can see some consolidation here and some chronic changes or athletic changes here. And here also we can give the result as focal pneumonia, chest X-ray focal pneumonia, and RT-PCR came as negative for this patient. So finally, this patient was treated as community acquired pneumonia. So here the teaching point is that a focal pneumonia can be either COVID-19 pneumonia or a bacterial pneumonia. So it can actually correlate with the RT-PCR result, and then also clinically also, and again serial X-rays, no need for taking a CT chest. And these are two conditions where we are almost sure that it is not COVID-19 pneumonia. It is something else, that is a bacterial pneumonia. So you should always watch for these findings. The first is a dense consolidation with cavitation. And second is a lobar pneumonia or a lobar consolidation. So you can see here the cavitation, and here it is involving the right middle lobe. Here say a lobar pneumonia, you can see the silhouette cardiac margin, and you can see the sharp horizontal fissure here. So these two cases, the rest of the lungs are clear. So in these two cases, we are almost sure that it is bacterial pneumonia, not COVID-19 pneumonia. Now coming to the another next case, that's a 56-year-old male coming with progressive dyspnea. There's a known COVID patient. A chest X-ray was taken on day 2, which is normal. But again, he had a progressive dyspnea. So a chest X-ray was taken on day 7. So now we are seeing multifocal consolidations predominantly in the lower zone. So this is the typical COVID-19 pneumonia, and you can give it as CXMP, that is chest X-ray multifocal pneumonia, and the correlative CT is showing peripheral consolidative patches, which is typical for COVID-19 pneumonia. So this is the typical appearance, chest X-ray appearance of a COVID-19 pneumonia, where you're seeing not very dense, the less dense multifocal consolidations bilaterally, predominantly basilar. And another case, that is a 38-year-old, is a young patient coming with fever and progressive dyspnea. Chest X-ray is showing dense consolidations now here. It's more in the bilateral lower lobes, also involving the left upper lobe. So again, you can give the report as chest X-ray MP, that is CXMP, CX multifocal pneumonia, and the correlative CT showing bilateral dense consolidations. So this is the final conclusion actually, which is given by the RSNA. Use of chest radiography will likely continue to increase as the COVID pandemic continues. Chest X-ray is often the only imaging test performed in the evaluation of COVID-19 and is used more frequently than CT in US. Chest X-ray aims to identify presence or absence of pneumonia or an alternative diagnosis, and is a tool used in decision pathways and patient management. Multifocal bilateral pulmonary opacities are non-specific, but most characteristic of COVID-19 pneumonia. Standardized language establishes uniform reporting as to the presence or absence of pneumonia, reduces report variability, facilitates data mining for analytics, and provides clear communication to aid in diagnostic and management decisions. This is actually the conclusion given by the RSNA. And so according to that, we should rely on chest X-ray for the imaging, for the diagnosis, as well as the, not for the diagnosis, but for the serial follow-up of the patients with COVID-19. So this is a article which is published in Medical Radiology in May 2020. That is, it is a study which is conducted in. This is for the scoring. So the scoring for all imaging, either it is chest X-ray, CT, or lung ultrasound, is very important, because just giving the scoring, we can actually classify the disease as mild, moderate, and severe, and it gives a clear picture to the clinician about the severity, and he can actually decide on the management. So this is called the BRCA score. There are two steps of image analysis. We should take a frontal chest projection. It can be either AP or PA, and we should divide these lung zones into three. So in a properly exposed chest X-ray and properly positioned chest X-ray, it's actually easy. We should, the first zone, the upper zone is just up to the inferior margin of the aortic arch. Second zone is up to the level of the inferior pulmonary vein, that is just below the level of the hilum, and the below zone is the lower zone. But in most of the bedside or the portable X-rays, it is very difficult to see the landmarks. So we should just divide the lung, whatever lung fields we are seeing, we should just divide it into three and take the scores by dividing. So the score is given for each zone. We are giving a score of 0 to 3. 0 means no lung abnormalities. Score 1 is interstitial or linear infiltrates. Score 2 is interstitial alveolar infiltrates or interstitial predominance. And score 3, we started seeing alveolar with a predominant alveolar predominance. So each zone, we have a score from 0 to 3. So maximum of 3 into 6. So maximum score will be 18. So the chest X-ray score ranges from 0 to 18. And if it's more than 6, that is, if more than 1/3 of the lung is involved, the patient needs hospital admission. And if it's more than 50%, that is more than 9, the patient requires intubation and mechanical ventilation. That's the significance of the score. So let's try giving the score for this chest X-ray that I have shown you before. Let's first divide it into 3. So here this is almost the inferior margin of the aortic arch, and this is the 3 zones: A, B, C, D, E, and F. So A means you're seeing predominantly interstitial opacities. We are not seeing any alveolar opacities. So we can give a score of 1 here, 1 here, 1 here, again 1 here, but here some small alveolar densities, but again it's predominantly interstitial. So for E and F, we are giving it 2. So total score will be 8 out of 18. So it's not more than 9, but definitely this patient needs hospitalization and serial chest X-ray follow-ups. So this we'll just try scoring this.
Reshmi, can you come a little closer to the microphone? The sound is too weak.
Now can you hear, sir?
Yeah.
Okay. This is the next X-ray. We'll just try scoring this. So here, this is the A zone. A zone, we are seeing interstitial opacities basically. B also interstitial linear opacities, no alveolar densities here. But when you're coming to the lower zone, Z, we are seeing dense alveolar densities. So here we are giving score of 1 here, 1 here, 3 here. And coming to D, this is the upper left side upper zone. This is 3 here, again 3, 3, because it is predominantly alveolar opacities in left side. So it will be 1, 1, 3, 3, 3, 3. So the total score will be 14 out of 18, which is very severe. So such a patient actually needs intubation and mechanical ventilation. So this is the significance of scoring these in chest X-ray. So just to conclude the chest X-ray, we should use a standardized language, that is no pneumonia. If the lungs are clear or the findings are stable. Indeterminate for pneumonia if we are not seeing hand consolidation, but we are seeing linear patches. focal pneumonia, if you're seeing a focal pneumonic patch, and multifocal pneumonia, which is typical, and we are seeing bilateral consolidation. So, and then after reporting it as these four, we should score it. That is, out of 18, we should give the score, and we can actually serially follow up the chest X-rays. Now, coming to chest CT, the CT findings, you all know, I may not go into details. This is the typical ground glassing where you can see the vascular markings. And this is the crazy paving. That is, crazy paving means ground glassing. That is the septal thickening superimposed on ground glassing. So the early findings will be just ground glassing. But as disease progresses, we'll start seeing the crazy paving. Septal thickening means, you know, that fibrosis has started settling in. So this is actually seen in after 1 week. And now the predominant vascular markings, it's again due to the inflammatory response. Is also very common finding in COVID-19. This is the traction bronchiectasis and fibrotic changes. These findings are seen late in the disease. And this is what actually seen when you see the resolving state. That is, after 2 weeks, you are seeing subpleural pleural bands, and we are seeing architectural distortion. So these are the typical findings that we see in CT chest in a patient with COVID-19. There are some rare findings like pleural effusion, pericardial effusion, lymphadenopathy, cavitation, CT halocine, pneumothorax, but this is very, very rare. And the point is that if we see pleural effusion or lymphadenopathy or cavitation in a pneumonia, in a non-COVID positive patient, we should think of the complication like superimposed bacterial infection. So that is the importance of picking up these findings. Advanced phase disease, I already told, we start seeing crazy paving, vacuolar sign, fibrotic streaks, air bronchogram, bronchus distortion, subpleural line, pleural effusion. So this says that it is actually progressing into a fibrotic stage. So this we already discussed. So now coming, there are some serial X-rays of the same patient. So this is the early finding where we are seeing bilateral GGO or ground glass opacities. As disease progresses, we start seeing the fibrotic changes. We are seeing ground glassing, but we start now seeing the subpleural bands here. So this is actually seen around 14 weeks. And this is what we are seeing after 14 weeks, that we are seeing like architectural distortion and so many fibrotic changes with traction bronchiectasis. This is another patient, the same patient. This is actually taken in the first 3 days, the first week. So second week, 14 days, and this is actually taken after 1 month. So you can see the small ground glassing actually progressed, and after 10 days, so the peak time is 10 to 14 days. After that, that area of involvement will not increase, and then gradually it starts resolving fibrosis. That is the typical pattern of the progression of COVID-19. So here you can see the resolving pneumonia by fibrosis. And the sad picture is that actually they are conducting many studies as to know the sequelae of COVID-19 pneumonia. So many studies are going on. The results are not yet out, but some interim reports have come, and they've shown that around 50% of the patients still have fibrosis. So it is not resolving completely, and that fibrotic sequelae is still there. So this is a lucky patient where the consolidations almost resolved here. And this is that one of the studies which is published in European Journal of Radiology. So here you can see that, see at stage 6, that is after 1 month, they have taken a serial CTs for so many patients, and they found that 98% of the CT scans still showed abnormalities. So for 98 patients, 98% of the patients still have some fibrosis or that residual abnormalities in the CT chest. It's not like a bacterial pneumonia which gets completely resolved. So that is the danger of this COVID-19 pneumonia. That is the fibrotic sequelae later. But still many studies are going on. Now, coming to the cohorts, actually, previously when the number of cases were less, this had significance because we used to diagnose cohorts by imaging or CT chest. Now the significance has completely, like it has gone down because we see a lot of patients with RT-PCR positive cases. So we don't use CT chest for diagnosis, but just for completion's sake, I'll just go through the cohorts. So this is a cohorts 2 case. Cohorts 2 means we are almost sure it is not COVID. So here what you're finding is centrilobular opacities with train bud pattern and some bronchial wall thickening here, which is so typical of a infectious bronchiolitis, which is very, very rare in COVID-19. So we give this as Corad's 2. Again, I told that if you see a dense lobar pneumonia, which is involving one lobe and rest of the lungs are clear, and if you see this train bud pattern here, again, COVID is very, very unlikely. So again, we give this as Corad's 2. And these are four different patients, and now you're seeing unifocal GGOs. Only like unifocal, you're not seeing anywhere else. But this can be very well be an early COVID pneumonia, but it's not typical, and you're only seeing one area of GGO. So in this case, we give it as Corad's 3. And this is almost like it's not typical, but you're seeing multifocal GGO and here bilateral, but it's not typical because it's not seen in lower lobes. It is more seenly in upper zones. So we give it as Corad's 4. And this is a typical bilateral GGO consolidation. We give it as Corad's 5. But I told you that's it's not of much significance now. And these are the typical and the very atypical findings we already discussed. And now coming to the CT score, actually it was mainly published in European radiology. There is actually a score which is published in RSNA in March, and this was published in July. The RSNA scoring is actually more difficult and is more confusing. They're actually using 20 segments, 40 score out of 40. But now I think this is more practical, and nowadays I think most of the hospitals are following this CT severity score. That is, there are 5 lobes we know. Each lobe we have to subjectively see, it's actually a visual impression. We have to see the involvement of the lungs in each lobe. And if the involvement is 0, we give it the score as 0. If there is very minimal involvement, that is less than 5%, we give the score as 1. 5 to 25%, that is less than 1/4 involvement, we give 2. Less than half, we give 3. If it is 50 to 75%, we give 4. And more than 75%, we give a score of 5. So each lobe we give a score of from 0 to 5. So there are 5 lobes. So the maximum score will be 5 into 5, 25. So the total score ranges from 0 to 25. That's how we score the findings in CT. And mild disease is less than 8. 8 to 15 is moderate, and more than 15, we give it a severe disease. Now coming to the complications, obviously we know the most dreaded complication in COVID-19, which is the ARDS. This is the patient progressing into ARDS. ARDS, we see dependent consolidation bilateral. It's almost sort of a whiteout lung here. And other complications, I already told, it's a pulmonary bacterial superinfection. We have to suspect bacterial superinfection if we see consolidation with cavitation or with pleural effusion or with enlarged lymph nodes. And another complication is a COVID-19 associated pulmonary aspergillosis, which is also a documented complication. But again, this is a case with invasive aspergillosis, but imaging wise, it is very difficult to differentiate a COVID-19 pneumonia from invasive aspergillosis. We have to actually go with the endotracheal swabs for further diagnosis. And now this comes the most common complication that we are facing nowadays, that is a pulmonary embolism. Previously, this complication was unknown, and we used to think that most of the patients actually, the mortality was mainly due to ARDS. But now the pulmonary embolism, this complication is very, very common. So, but we routinely don't do a routine CT pulmonary angiograph if not indicated. But when to take a CT pulmonary angiogram? That is when there is a clinical radiological discordance and or respiratory worsening in a known COVID-19 patient. That is, we can't actually, we are like, there is the chest X-ray looks almost okay, but the patient is having acute hypoxemia or acute respiratory worsening. Then we have to think of pulmonary embolism, especially when the patient has a highly elevated D-dimer levels. So this is a patient having not very severe pneumonia, but the CT pulmonary angiogram showed linear filling defects within the segmental arteries, the dissenting pulmonary arteries here. So pulmonary thromboembolism in COVID-19 involves mainly the segmental and the subsegmental arteries of segments affected. And why this pulmonary embolism occurs? Is it due to the embolism from the pelvic or the DVT? It is not. So it is basically, it is occurs due to the severe lung inflammation and hypercoagulability rather than thromboembolism. And it is very, very common in more severe COVID-19 pneumonia. That is, that if the CT severity index is more, you should always look for a pulmonary thromboembolism if and give contrast if needed. So that is the main importance of looking for pulmonary thromboembolism, which is, and in a study, in a recent study, they have shown that almost 35 to 40% of the
ആർക്കാണ്ട് ഫുഡ് കൊണ്ടുവന്ന് താഴെ നിൽക്കുന്നു.
around 30 to 40%, 35 to 40%.
ടൊമാറ്റോ പോലത്തെ ഒരു വണ്ടി ആരെയോ വിളിച്ചോണ്ട് കുറച്ചു നേരമായി താഴെ നിൽക്കുന്നു.
Sir, can you unmute others?
മിലിയുടെ ശബ്ദമാണ്. മിലി മ്യൂട്ട് ചെയ്യാമോ? ഭക്ഷണം കൊണ്ടുവന്നതൊക്കെ ഞങ്ങൾ കേട്ടു.
അയ്യോ സോറി.
അല്ല, മിലിയാണെന്ന് എങ്ങനെ മനസ്സിലായില്ലേ?
ആ, മിലിയുടെ അടുക്കളയിലെ ശബ്ദം വരെ ഞങ്ങൾ കേട്ടിരുന്നു. പിന്നെ ഭക്ഷണം കൊണ്ടുവന്നതും കേട്ടു.
ആഹാരം എന്ന് പറഞ്ഞാൽ മിലി എല്ലാം മറക്കും.
Okay, so continuing. So the possible role of CT is triage of the patients, but now the main role is actually CT is only used as a problem solver in the prediction of worsening bar complications and the prediction of improvement. So routinely we don't recommend CT nowadays. But again, we should know the structured reporting format in CT chest. So this is there is a link here I've given here. So this, we just need to enter the findings and they will give that standardized report. So these are the things we should give all the clinical information. And for GGOs and consolidation, we should give the location, that is whether it is bilateral or unilateral, and you should give the distribution in the axial plane as well as the craniocaudal distribution. Axial plane we should give whether it is peripheral, central, or dependent on decubitus. And the craniocaudal distribution we should give whether it is multifocal or predominant in the upper lobes or the lower lobes. This is the standard reporting format. And consolidation is also same thing. We should give the location, distribution in the axial plane, and distribution in the craniocaudal distribution, and other features like if there are crazy paving, fibrosis, pleural effusion, cavitation, nodules. So all these can be given as ancillary findings. And should also always comment on the mediastinum, about the lymph nodes, pericardial effusion, the vascular findings, which is very important. I told the pulmonary artery trunk diameter, pulmonary embolism plus or minus, subsegmental vessels enlargement, and if there is another findings like pneumothorax, pneumoperineum, or the subcutaneous episode. So this is the standardized reporting format that we follow. So I'll just show you two cases just to show how we are reporting. So this is a case which was taken in our hospital in August 7th. Actually, this patient is a 60-year-old male coming with progressive shortness of breath. He was not a known COVID patient. So now in the CT, we are seeing multifocal consolidations and ground glassing. It's predominantly ground glassing, but all are typical peripheral, some traction bronchiectasis and some fibrotic changes are set, because we are taking it around the 10, that peak time, and some fibrosis have set up. So we should give it as peripheral GGOs. Additional findings, we can give it as vessel enlargement, some traction bronchiectasis, some subpleural bands. And now we'll try scoring the severity index. We can see that it's almost uniform. It's not upper lobe or lower lobe predominance. And we can see it is in all the lobes, it is involving less than 25%. So it is around 5 to 25%. So now the scoring will be 5 to 25%, it will be 2. So it's almost uniform in all the lobes. So the final score will be 2 into 5, that is 10. So this is the coronal showing the same patient. And this will be the final report. So we are telling about the ground glass opacities, consolidations, peripheral, no predominant distribution, and this is the severity score we have to give. That is upper lobe. All in this case, it's almost uniform everywhere. So we gave 2 each, and the total severity score is 2. This was not a non-case, so we gave a score as 5 and total CT severity index of 10. But ultimately, after the CT, the RT-PCR came as positive. So this was actually a COVID pneumonia, confirmed COVID pneumonia. Now coming to the next case, this is again an elderly coming with shortness of breath. Now here it is more of consolidation. So you're seeing peripheral ground glassing in the upper lobes, but when you're coming to the lower lobes, it is dependent consolidation. So these are the key words: peripheral ground glassing in the upper lobes and dependent consolidation in the lower lobes. Actually, the patient is going for ARDS. So this, when we start scoring, we are seeing that the if you start seeing from the upper lobes, in the upper lobe it's almost 75% is involved, and this is less than 50%. So this will be 3 here, and this will be 2 here. Sorry, it will be 4 here and 3 here. And coming lower down, both the and middle lobe is also like it's almost involving 50%. So it will be 3 here, but again here it will be 4 because it's almost involving 75% lower lobes. So this is the mediastinal window where the consolidation is clearly seen. This is the coronal view, which is showing the upper lobe GGOs and the lower lobe consolidations. So this was the report, both GGO, ground glassing, peripheral, predominant distribution lower lobe, predominant AP distribution dorsal, that is a dependent. And we gave the score of right upper lobe 4 because almost 75% is involved, right middle lobe 3, lower lobe 4, upper lobe 3, and left lower lobe 4. So the total severity score comes around 18 out of 25. So it was a known COVID patient. So CORAD 6 and severity score is 18 out of 25. The patient definitely needs mechanical ventilation. So now coming to the last part, that is the lung ultrasound part, we call it as point of care ultrasound or POCUS. I don't know like how many of us are doing it. There is actually a controversy in many hospitals, even in AIMS, the intensivists are doing the point of care ultrasound. But here in Gogulam Medical College, Vishak sir is doing it, and he has actually trained all the radiologists and the PGs there to do the POCUS. So still that controversy is running, but for completion's sake, and at least in this COVID era, we should all know about POCUS and how to do it. So I'll be dealing it in not very detailed, but in short. So now actually it is the imaging modality that we have to use in diagnosing as well as following up a patient with COVID-19 pneumonia. It has got accurate diagnostic ability. The main advantage is that it limits the rate of cross contamination. We all know, just like a portable X-ray unit, we can use a portable ultrasound machine. We can use a dedicated one for a COVID ICU, and we can use it in the bedside. And it can do it very, very rapidly. You can just, it's a point of care that we can just see the areas and do it in a quick way. There is no need for transportation of the patient. So it's a safe, rapid, and a promising tool in diagnosing this contagious viral disease, especially in the ICU setting. It is superior to chest X-ray. So many studies are there, and they're showing a sensitivity of 94% and specificity of 89%. So it is shown to reduce healthcare worker exposure to COVID-19 by reducing the intra-hospital transfers associated with conventional imaging. Reduced cost, repeatability, we can repeat it at any time. There's lack of radiation exposure and rapid image acquisition time. So these are the advantages of lung ultrasound. So this is how we do. We actually divide it into the whole chest, one side, into 6 segments. This is the anterior, lateral, and posterior. So anterior, this is the parasternal line, anterior axillary line, posterior axillary line. So anterior, you have 2 segments here, lateral and posterior. We should keep the probe. We can either use a curvilinear probe or linear probe, but curvilinear probe is actually, it gives the depth. So we use the curvilinear probe, and the probe is actually kept in the craniocaudal direction. That is, it is the ribs are like this. It is actually kept in a perpendicular to the ribs, and this is a normal finding that you see. These are the shadowing of the ribs, and this is the lungs in the intercostal space. So these are the reverberation artifacts of the A lines. This is a normal appearance of an intercostal space. The ribs, the acoustic shadowing, and here the reverberation artifacts of the A lines. This is the normal appearance of a lung ultrasound. And sometimes we see a B line, which is also normal. B line is a line which is seen parallel to the shadowing of the ribs. So this vertical line is B line, and this is a normal A line. This is also normal. So one B line is normal. 1 or 2 B lines is normal. So this is again a normal appearance. But now here we have started seeing some hypoechoic areas in the subpleural aspect. So here in this case, you can see this is a normal smooth pleural lining. So this is normal. When we start seeing irregularity of the pleural line with subpleural hypoechoic areas, then it starts becoming abnormal. So this we have to, in a COVID-19 patient, we should always look for this subpleural consolidations here. So this is the early subpleural consolidation that we see in COVID-19. This is also you're seeing small subpleural consolidation. This is actually the very early stage when we are started seeing the subpleural consolidations. Now this is the frank consolidation here. It is seen in a very late stage. You're seeing consolidation means, yes, you all know, hepatization of the lung with air bronchogram which is moving. So this is the typical appearance of consolidation. This is again a subpleural consolidation here, but now this is a large one. And this is actually very characteristic, the confluent B lines or the increase in number of the B lines. You can see so many vertical white lines here. So that corresponds to the GGOs in the CT chest. So you should always look for the B lines, the number, the confluent B lines, subpleural consolidation, and finally the collapse of the lung. So these are the findings you should look for in a lung ultrasound. So this shows the deterioration of a patient in COVID pneumonia. This is the normal. We are seeing the normal A lines, and the pleural lining is smooth. And now you start seeing pleural irregularities and the B lines you are seeing. And later it shows more progression. The number of B lines are increasing and some of the B lines start confluent B lines. Subpleural, we start seeing small subpleural consolidation. And this is the late stage where we are seeing frank consolidation with air bronchogram. So this shows the deterioration of a patient with lung ultrasound. The vice versa also happens. So this shows the improvement of the patient. If the patient has consolidation, then B lines, the number of B lines increase, and this is the normal aeration. So from this to this, we can see that the lung aeration is increased from 100% to 0%. So in lung ultrasound, clearly we can see all these findings, and actually it can help in the management of the patient. So this is the nomenclature that is used in ICU, because so many patients, it will be always difficult to write the whole thing. So A is normal, B1 is more than 2 lines, 2 or more B lines, you can give it as B1. B2 is presence of covalent B lines. C is small peripheral consolidations less than 2.5 centimeter. If it's more than 2.5 centimeter, it is CC. Lobar consolidations triple C, and presence of pulmonary atelectasis is triple A. So this is like, if you want, you can follow, or otherwise forget it. So according to WHO, with COVID-19 patients requiring hospitalization for moderate to severe disease, they require supplementary oxygen and regular monitoring that facilitates early recognition and escalation of the deteriorating patient. Recommendations are that patients receiving respiratory support should be monitored closely for clinical deterioration, and serial lung ultrasound imaging may help inform this. So even the WHO now is recommending lung ultrasound or POCUS for the management of COVID-19 patients. So again, there's a score for that. As I told, one side there are 6 zones. So bilateral, it will be 12. So maximum score is 36. So the same, we can go with the same thing. So this is 0, 1, 2, and 3. So these are the the score that we give. So one zone is maximum score is 3. So the whole 12, it will be 36. So we have to give the scoring out of 36. So total lung score of 0 makes pneumonia very unlikely, and it allows a rapid assessment of the pneumonia severity by the total LS, or even more quickly the anterior region. So bedridden patients, is very difficult to make the patient side or like into the sides or decubitus position. So we just need to see the anterior region. So we all know that anterior region is mainly the upper lobes, and the upper lobe involvement comes very late. So if we see an anterior region lung score of 4 or higher, then we should know that the patient probably need a non-invasive respiratory support or a NIV. And if it again it goes more, we need to actually mechanically ventilate the patient. So that is the main significance of this lung ultrasound. So this is a study which is published in the intensive care medicine. More lung ultrasound actually they are publishing in the intensive that the critical care journals. So in that they have come with this score that is based that both mortality and need for invasive mechanical ventilation were increased with baseline lung ultrasound score of more than 18. That is, out of the 36, if the lung ultrasound score is more than 18, the patient invariably goes for mechanical ventilation, and there is high chance of mortality. So this is how they actually in that study they have concluded, that is, if there are small B lines which are not confluent, the patient needs supplemental oxygenation. If the disease is severe, that is, if the B lines become confluent and small consolidations appear, the patient may need NIV. And if there is extensive coalescent B lines and large consolidation, the patient anyway need a mechanical ventilation. So that is how they actually manage the patient according to the lung ultrasound findings. So we can also see for the pleura, the diaphragmatic mobility, other findings also in lung ultrasound. Out of which the caliber of inferior vena cava is also very important, because we know that patient is going for a hypovolemic shock. So that is about the lung ultrasound. So to conclude, chest X-ray is the mainstay imaging in COVID pneumonia. That is the baseline imaging. We don't use CT chest right now. CT is used only as a problem solver or when suspecting complications like pulmonary embolism. And lung ultrasound is the choice of imaging in ICU, which helps in the management of the patient. And we should use standardized terminology and reporting formats for all patients to avoid confusion. And always try to give a severity score, either if it's a chest X-ray or a CT or a lung ultrasound, always give a severity score, which helps the clinicians to decide on the further management. So that's all. Thank you.